Good evening. I'm Dr. Nivedita Venkateswaran. I'm a second-year plastic surgery resident at Ganga Hospital, Coimbatore. Today, I will be presenting a case of adult brachial plexus injury. Coming to the history, my patient is a 26-year-old male orthopedic resident. He's a second-year resident at Bangalore. He's right-hand dominant. Who presented to us with complaints of weakness over the shoulder and the elbow on the right side since the past 5 months. He sustained a history of road traffic accident, that is two-wheeler versus four-wheeler, 5 months back, after which he had a closed injury to the right side of his neck and shoulder. After the injury, he noticed weakness and inability to lift the right shoulder and bend the right elbow. He does not have any complaints of intolerable pain. There are no other injuries, that is head injury, clavicle fracture, vascular injury or chest injury. He did not sustain any open wounds. There is no improvement in the weakness since the injury. He does not have any sensory changes or alterations, no loss of sensations, and no history of fever. Coming to the past history, he has not undergone any previous surgery, and he does not have any comorbidities. Personal history, there are no alterations in his sleep, bowel, bladder or appetite, and he does not have any addictions. Treatment history, since the injury, he has been on regular physiotherapy at home for passive mobilization of the joints of the right upper limb. This is the presenting picture 5 months after the injury from the front and the back. Coming to the examination, my patient is conscious, oriented to time, place and person. He is vitally stable. He does not have any signs of pallor, icterus, cyanosis, clubbing or lymphadenopathy. Under local examination, the attitude of the right upper limb was with the shoulder adducted, the elbow extended and internally rotated. The forearm was pronated, wrist neutral and fingers were extended. On inspection, there were no signs of Horner syndrome. Shoulder asymmetry was noted with wasting of the shoulder muscles on the right side, particularly the deltoid, the supra and the infraspinatus, the biceps, clavicular part of the pectoralis major. The sulcus sign was positive on the right side. The winging of scapula could not be appreciated. There were no scar marks, sinuses or fistulas, and the opposite limb was normal on inspection. This is a picture showing a limited shoulder abduction on the affected side. Elbow flexion was also restricted on the affected side. The wrist flexion extension were normal and finger flexion extension was also normal for this patient. This is a short video showing the movements of the patient with shoulder abduction, which was limited on the affected side. Elbow flexion, the patient is not able to flex his elbow. Okay. Coming to the motor examination, the rhomboidus, the serratus anterior, the supra and the infraspinatus muscles were not working for this patient. The trapezius had a power of 5/5, latissimus dorsi 4/5. The biceps was not working. Also, the brachioradialis and supinator were not working. All the other radial nerve innervated muscles, the hand, wrist, and the finger flexors and extensors were normal. The range of motion, the shoulder did not have any active range of motion, but the passive range of motion was full, so there was no stiffness. Same with the elbow, the flexion was not present. but the passive flexion was possible. Extension was present from 0 to -10 and passive extension was possible. Wrist and finger had full and free range of movements. Tinel's sign was absent. The sensory assessment showed no sensory deficit in the hand for this patient, and the peripheral pulses were felt. So my diagnosis is a post-traumatic upper brachial plexus palsy involving C5-C6 nerve roots of 5 months duration with absent shoulder abduction and elbow flexion on the right side, showing no signs of recovery.
I think Dr. Bhandari, sir, you can start. Request everybody to kindly mute it, except Dr. Bhandari.
Bhandari sir.
Bhandari sir, you are muted.
Okay. Whenever we do the examination of a brachial plexus patient, we must do the examination of the pulse, whether it's a partial injury or total injury. Usually in total injuries or in infraclavicular injuries, there is sometimes vascular damage, subclavian or axillary artery, and we must include it in the examination part. Means we must feel the radial pulse. Number two, when we do the investigations, we must take an X-ray of the chest to see the movements of the position of the diaphragm on the both sides. This is a very basic kind of test, and it gives a lot of information. It is not necessary that the diaphragmatic palsy or phrenic nerve injury is always there in, not always, but it is usually there in total palsy. I have seen even in the partial injuries also, the diaphragm is sometimes paralyzed. So these two I wanted to tell you, which were probably not covered in your history and examination part.
Okay,
Coming now to the investigations, you have what investigations you like to advise for these patients apart from routine test?
Purushothaman sir.
He has covered the clinical examination. In this part of clinical examination, anything you wanted to contribute additionally, or you want her to focus?
I think history part has been very well presented, and let's see what is the plan about the treatment management as such.
So under investigations, apart from the routine surgical fitness, we'd like to test X-ray to rule out any phrenic nerve injury. Further radiological investigations would be an MRI of the brachial plexus. We also X-ray of the cervical spine to rule out any transverse process of the cervical vertebrae fracture. Nerve conduction studies can also be done to give us an idea of.
Just wait here.
Yes,
why you want to do the X-ray of the clavicle, and why you want to do the X-ray of the chest? Why you want to do the X-ray of scapula? Any relevance to that? What is the idea behind that?
Sir, if there is a scapula fracture, then it is possible that the suprascapular nerve may be injured. If there is a clavicle fracture, then again it is suggestive of injury to the brachial plexus. X-ray chest will tell us whether the phrenic nerve is injured or not, which could be a possible donor for us later if we want to plan a nerve transfer. And cervical X-ray will tell us if there is any root level injury of the cervical nerves.
Yeah, Dr. Purushothaman.
Doctor.
Yes, sir.
What was your finding of the shoulder?
So the muscle wasting was present.
Is it totally paralyzed?
So shoulder abduction is absent.
Totally absent? There's no movement at the shoulder?
You can say weak, sir.
Weak and all is
No, it's absent is absent. You have to say absent or
absent means absent.
Absent.
So what is your muscle chart say? You say the rhomboids is negative. Am I correct?
Yes, sir.
Rhomboids, levator scapulae, serratus, everything is absent.
Yes, sir.
That means you must have winging of scapula.
Yes, sir.
Is there a winging of scapula?
Sir, in this patient, I could not appreciate it, sir. The medial border of the scapula was not becoming prominent.
No, how do you test for rhomboids?
Sir,
you
in
put it as
the...
zero. You have put it as zero.
Yes, sir.
Levator, rhomboids, serratus, everything you have put it as zero. Without examining, how can you put it to zero? Is there a winging? That's what I'm asking. Is there a winging or not?
So clinically, the winging could not be appreciated.
Could
Sir.
not be appreciated. Then how will you examine rhomboids?
So,
Without examining rhomboids, how can you say zero?
so we palpate for the medial border of the scapula when we ask the patient in the supine position to lift his outstretched arm and palpate for the medial border of the scapula. So if the muscle is contracting, the rhomboids is contracting, then we can feel it.
So examine in supine position.
In the prone position, sir.
Prone position. Make him lie down and do it.
Yes, sir. We eliminate the gravity and then we can test if it is working.
I don't think you are correct in saying that. So there is some forward flexion. At the shoulder, there is some forward flexion. It is not totally hanging by the side.
Okay, sir.
So what do you think is the cause for lifting? That is what is the question, Nivedita. The cause of lifting forward, is able to lift now a little bit. That's what
Yes,
Sarist asked. We understand there is a lot of fat, is difficult to examine, but something is controlling his shoulder other than the muscles which you have mentioned, which is paralyzed. So what are the muscles still working on the shoulder joint?
What about pectoral?
So there is some amount of wasting in the pectoral, but internal rotation is weak for this patient. So pectoral clavicular head is not working.
External head is working.
Flickering movements are there, sir. So sternal head could be working.
I think that examination was not complete. If you say they're all negative, I take it as what conclusion you draw when you say rhomboids is not working and serratus is not working.
Sir, it means that it is probably a preganglionic lesion. That is a root level.
Lesion, the root level lesion. And you say Tinel's also is negative.
Yes, sir.
What does it mean?
So Tinel's negative also suggests a preganglionic lesion.
So according to you, it's a preganglionic lesion.
Yes, sir.
Okay. So now you can proceed with probably the investigation, or Bandari can continue.
Yeah. So you have told about the radiological test.
Yes,
And here just I wanted to tell all the students that whenever we do the x-rays of the clavicle or the scapula, we must see where is actually the fracture and how much is the displacement, especially in clavicular fractures. If the displacement is quite significant, wide displacement, then there are good chances that there could be an associated injury to the suprascapular nerve, which is our target nerve. And also sometimes in very wide displaced clavicular fractures, there is likelihood of an injury to the spinal accessory nerve. So this I wanted to convey to you all. And when we do the scapular X-rays, we must see where is the fracture. Is it across the suprascapular notch? Probably for this, X-ray chest may not be sufficient. The patient might need CT scan or 3D CT. And this is also important because if we are doing some surgery for the suprascapular nerve, we have to explain to the patients well in advance that how much we are going to be successful. If there is so much of trauma to the scapula, like comminuted fractures, fracture passing through the suprascapular notch and all, your results are uh, likely to be inferior in such cases, and this is very important to convey to the patients before the surgery. And after the chest X-ray, do you think that the mere examination of the chest X-ray, you are able to tell the diaphragmatic positions, or you like to do some other tests also? What is the relevance of doing the chest X-ray? Just only to see the diaphragm or anything else also?
Sir, any rib fractures are there, then intercostal nerve damage also can be assessed on chest X-ray.
What about the phrenic nerve injury? Do you think that by doing chest X-ray we are 100% sure about the injury? If the
Sir, we can.
diaphragms are normal, then we should take it as the normally functioning phrenic nerve, or we should do something extra?
So, pulmonary function.
Agreed. What happens that generally we are able to pick up the diaphragmatic palsy in the routine chest X-rays, but taken in the standing position. But the most important will be to see the movements of the diaphragm, and that will be possible by doing an ultrasound chest. So it is always good to do ultrasound chest before going for surgery. And what is the relevance of phrenic nerve? Why we want to know about the status of the phrenic nerve in brachial plexus patients?
Sir, if the phrenic nerve is uninjured,
Yeah.
then we can use it as a donor. It lies adjacent to the brachial plexus, so the nerve coaptation and all will be easier. It may not need very extensive nerve grafts.
Generally, if you are doing it for suprascapular nerve, there may not be need of a nerve graft, but for the musculocutaneous, it requires always a graft. And phrenic nerve is generally taken as a good donor nerve when other nerves are not available, but must understand that it has got its own morbidity, and this morbidity is more on the right side compared to the left. Why?
So because the liver is the
The reason is right side lung has more to contribute to the vital capacity. Right lung has got 3 lobes, and left has got 2 lobes. So right is more dominant than the left in normal individuals. So it is seen that whenever we do the phrenic to axillary or to musculocutaneous nerve transfer, the dyspnea, breathlessness in the early post-op period is more often seen in the right harvest than the left. So one should be little cautious before selecting the phrenic nerve as a donor nerve. And it should not be done in obese patients. It should not be done in a patient who has got a history of lung contusions also. Before taking the phrenic nerve, we must see the condition of the contralateral lung also, because these are polytrauma victims, and many times they have sustained lung contusions also, which might not have been recorded on the documents. So one should very carefully examine the other lung, the normal contralateral lung, before we take the phrenic nor as a donor. But this should be the last choice.
Okay, sir.
And apart from X-rays, what other investigation you'd like to do?
So we can do nerve conduction study,
Before that,
MRI of the brachial plexus, sir.
yeah. What information you'd like to get by doing MRI?
Sir, in MRI, if we see that there are pseudomeningocoels, and then we can it will act as a guide for us during surgery. It is possible that it is a root level injury, like what we are suspecting, whether it is in.
When should the MRI done? What is the right time to do the MRI in brachial plexus injury? Immediately or
No, sir. We
within a
wait for 4 to 5 weeks, sir. At least
Why?
1 month.
Why?
So the tissue edema will subside by then.
Usually 3 weeks.
What is the genesis of these pseudomeningocoels?
So the dura will heal around the injured nerve, and that will give rise to the pseudomeningocele.
Yeah, generally what happens whenever there is an avulsion of the root, the dural tears, they take around 3 to 4 weeks time to get sealed. So the CSF which gets collected in those spaces, it appears as pseudomeningocele. So one should not be advising the MRI immediately. One should wait at least 3 weeks time before we advise the MRI. What are the other advantages of MRI over the CT? Earlier CT Milo used to be done. Now it is more or less obsolete, CT used to give very good idea about the condition of the nerve roots. But now CT Milo is not done. We trust more on the MRI. And what is the advantage of MRI over the CT?
Sir, it is non-invasive. CT myelogram is invasive.
And exposure.
Radiation.
Okay, exposure of radiation. And the most important is that MRI gives information about the distal plexus also. If you see the if you examine the carefully these patients MRI, you will find that you'll see a lot of hyperintensity and some irregularity in the region of the trunks and the cords. So this gives information about the condition of distal plexus also. So that is advantage of MRI over CT scan. What else? Why we are interested about knowing the pulse, radial pulse?
Sir, if there is any concomitant subclavian artery injury, and vascular injury during the accident.
Do you expect arterial injury in upper plexus injury?
Sir, in
clinically, we have diagnosed as a C5-6 lesion or upper plexus.
Yes, sir.
Do you expect arterial injury in such lesions?
No, sir. They are more common in postganglionic lesions, sir.
They're more common
in
infraclavicular injuries.
Here, where do you suspect is the injury?
What should be done if a patient comes with brachial plexus injury as well as the vascular injury? What should be done?
Sir, we will do the vascular repair first, and after it heals, we can operate for the brachial plexus.
So it is necessary that all patients, those who have got vascular injury, they should be subjected to the vascular repair. What we lose if you don't do the vascular repair?
Have you seen any repair being done for brachial plexus?
So subclavian artery repair has been done for patients.
If you
who
diagnose a subclavian artery injury on day 1 or day 2, definitely it warrants a repair.
Yes,
But sometimes it's ignored totally, especially in a closed injury. You may not realize it. You will realize only later that the patient has got a subclavian artery injury. But the limb survives. How?
So maybe some collaterals are formed and they are perfusing the limb.
Collateral from where to where? So you will have to check the pulse. You have to check the pulse, and sometimes even with the subclavian artery injury, the pulse will be feebly felt or something like that. But if they diagnose on day 1, ideal is to repair. Because even if it survives on collateral, the blood supply will not be very good for your nerve to regenerate. You need a lot of other procedures apparently, like sometimes you can even you go for a free muscle transfer. So you need a lot of blood vessels, donor vessels there, recipient vessels there. So ideal is to have a normal environment for the nerves to grow. So if you diagnose subclavian artery on day 1 or immediately, ideal is to repair it. Not hurry.
So when you're operating on brachial plexus, the first thing you should know the anatomy of subclavian artery. So what are the parts of subclavian artery? So that will answer Dr. Purushothaman sir's question. So basically subclavian is divided into 3 parts. Okay, proximal to the scalenus anterior, behind the scalenus anterior, and lateral to the scalene anterior. At the border of first rib, it becomes axillary artery. So normally the injury is to the second part or the third part of subclavian artery. So the collateral develop between the transverse cervical artery from the first part and go to the scapula. So it goes via the circumflex-scapular or posterior humeral arteries and forms an arch behind. That's how the collateral develop with subclavian artery. So now most of the centers have vascular surgeons. So if the vascular surgeons see them, as sir mentioned, they will always go for or prefer a repair. So if you see them at that time, the only thing you can do is tag them and come out. It is very difficult to do along with them. The reason why you should tag them or be careful is when they do a vascular repair, most of the time they put a stent, a Dacron stent, they will put a prosthetic graft. So when they put a prosthetic graft, it never remains in the anatomical position. It will be a little oblique or not in the anatomy. So when you go back and do your repair, then it will be very difficult subsequently. So these are the things you should keep in mind when we have a subclavian artery injury.
Okay. So you have done all investigations. You said neurophysiological studies, nerve conduction study.
Yes, sir.
In this patient, what is that you want to know?
Sir, it can confirm that it is a preganglionic lesion if we do a sensory nerve action potential. So if the SNAP is present, that means that the dorsal root ganglion is still providing sensations. So it is confirmed that it is a preganglionic lesion.
What group of muscles interested in seeing?
You said some muscles were paralytic. 0, 0, 0. You put at least 3 or 4 muscles, you have put 0.
Yes.
You want to see those muscles?
So we can confirm whether there is any fibrillation potential in those muscles also.
You specifically ask for that.
Yes, sir.
Along with that, what happens? How is brachial plexus formed?
So from the spinal cord, there is an anterior horn and the posterior horn, and then that will give rise to the spinal nerve, and the spinal nerve will further divide into ventral and dorsal rami.
So what
And
happens to
then-
the dorsal rami? Ventral
So
rami
they-
forms the brachial plexus.
Brachial plexus, yes,
So
sir.
what happens to the dorsal rami?
So they will provide innervation to the paravertebral muscles and the paraspinal.
They provide along the paraspinal region the sensation, as well as you have all the erector spinal
Motor.
like muscles,
Yes, sir.
the spinal muscles, paraspinal muscles. So you specifically ask for paraspinal EMG.
Yes, sir.
That is not there. Those muscles, that it is very difficult because they are all continuous muscles from top to bottom, from the skull to the coccyx level. So segmentally they have to see. Specifically, you have to look for those paraspinal EMG, and if they are not working, those muscles are not working, and there is no sensation in those areas, then you take it granted for the dorsal, that ramus is also involved, and so it must be a preganglion. Okay. So apart from your paralyzed muscles like serratus, rhomboids, all this you have to do, along with your paralyzed muscles like deltoid, biceps, brachialis, everything you have to do.
Yes, sir.
Okay, along with that, you have to ask for this. Only this will give a clue, because that all you examine, you know it's all paralyzed. Now your further investigation is to further guide you to come to a conclusion, whether it is preganglionic or postganglionic. Why do you want to come to that conclusion?
Sir, it will tell us whether the further line of management we can do a nerve repair or a nerve transfer. If the lesion is preganglionic, then a nerve repair is not going to be our plan. So we can do a nerve transfer for those patients.
Yes, but they cannot regenerate on their own. Okay, so you have to plan something like a nerve crossing or a nerve transfer. Okay, you can proceed.
My plan will be to do an exploration of the brachial plexus. If the roots are healthy, then yes, sir.
MRI is there or not?
No, sir.
No conduction?
No, sir.
Okay.
If the roots are healthy, then I would like to do a C5 to posterior division of upper trunk or the lateral cord for the elbow. C6.
How do you know the roots are healthy?
So we can stimulate them intraoperatively using a nerve stimulator.
What will happen?
We can see the muscle contracting, sir.
Where? Which muscle contraction? C5 you are stimulating. What muscle contraction you will see? What?
The shoulder.
In this case, when you have already mentioned that the dorsal scapular is 0, the long thoracic is also 0, do you still think that he would have some intact nerve roots?
No, sir.
Then why to make this kind of course, the final diagnosis of or the final planning of management is made after exploration only. These investigations are just, they are taken as guidelines, you know, but
Yes.
final the what actually we want to do, that we decide after exploration. But most of the time diagnosis is more or less certain, and our planning is more or less certain if we have done MRI, if we have done proper clinical examination, and if we have done the electrophysiology, isn't it? But
Yes.
what we see in this patient, in this boy, that he's got hardly any abduction, you know, the arm is just stuck to the chest. In such cases, and there is a positive groove sign, there is lot of wasting of the shoulder muscles. In such cases where there is not even means when the arm is totally stuck to the chest, there is, we can take an indirect evidence of root avulsion. Indirect evidence, I won't say all the time you are right, but when the arm is completely stuck to the chest wall, and even while attempting the abduction, we take it as that probably he has got root avulsions, upper roots. In fact, in one of the meetings I mentioned about this, that is open axilla sign. If you can pass a book freely between across the axilla, just like we do a Froment sign test for ulnar nerve injury, if you can pass a book, not Froment, scar test for ulnar nerve injury, if we pass a book across the axilla without much of problem, it is likely that one or two or one or more roots are intact. Okay, but in this particular case, what we see is that there is hardly any abduction, not even 5 degree of abduction. The arm is completely stuck to the chest wall, so it is assumed that he has got preganglionic injuries. Okay.
So, in this case, I would like to go for distal nerve transfer. For the shoulder, I would like to do a spinal accessory to suprascapular nerve and the medial head of the triceps branch of the radial nerve to the axillary nerve. For elbow, motor fascicle of the ulnar nerve to the biceps branch of the musculocutaneous, and a motor fascicle of the median nerve to the brachialis to the musculocutaneous nerve.
So immediately you jumped from no repair to distal nerve transfers. Okay. Because when you say Kinnell's is negative,
Yes, sir.
and rhomboids, Serratus, everything is absent, most probably it's all preganglionic lesion.
You must have seen good number of cases of upper brachial plexus injuries and their surgical procedures also. In how many cases you have seen that the roots were working in upper plexus lesions? They were responding very well to the electrical stimulation. It's a quite common finding, or it is a very, very rare finding?
Sir, in upper plexus, rupture is more common than avulsion.
Right?
No.
So,
Why did you say that?
Why is it so? Why you think?
because the C5 and the C6 nerve roots, they have a firm attachment to the transverse, ligamentous attachment to the transverse process of the cervical spine. So, given the intensity of the trauma, there will be rupture more commonly as compared to avulsion.
Still, you
It
can
is
have avulsion of C5 or C6. Isolated C5 can be normal, C6 can be avulsed. Actually, in my lecture, I show two cases where you have these kind of findings. So,
but
avulsion is also common, but pseudomeningocele is more common in lower plexus than upper plexus. That's what I feel.
But here also you should know that whenever some root is ruptured, most of the time you'll find positive tinel sign.
Okay, sir.
Rupture, you will have Kinnell's. We are not sure whether it is C5 or 6, but some root is there for you to repair. That you will have to explore and see, and again stimulate there and see. And you have found two roots are there, C5, 6. They are joining to form the upper one. Okay. And
Yes, sir.
that where it joins, there's a lot of scarring is there. You stimulate, there's no response beyond that. Proximally, you want to check whether the root is healthy or not. How will you check that?
Dorsal scapular nerve, we can check, sir.
Where will you look for that? Which is easier to look into?
No, sir is asking
The long thoracic
is
nerve
for-
is easier to check, sir. Serratus nerve to serratus.
How is long thoracic formed?
C5, C6, C7, sir, at the root
So
level.
you have one branch from each going to form the long thoracic. So posteriorly, just behind the C5-6, you look, dig there, try to dissect those which forms the long thoracic. Try to stimulate them. And if they are working, that means the proximal, that 5 root or 6 root is intact, healthy. You can utilize that for your nerve. Okay.
Yes.
Which are the target muscles for reanimation of the shoulder? Which
So-
muscles you want to neurotize?
So the deltoid and the supraspinatus.
What will supraspinatus?
The deltoid the axillary nerve will supply the deltoid.
Okay.
So we would like to provide innervation to the axillary nerve. And the supraspinatus will be supplied by the suprascapular nerve.
Only supraspinatus.
What else is supplied by suprascapular now? What all he lacks other than abduction? What is
Supraspinatus and infraspinatus, sir. Infraspinatus will give external rotation.
external rotation? Yes.
External rotation. So axillary nerve supplies only deltoid. Axillary nerve.
Yes, sir.
What are the components of axillary nerve?
Sir, it will also give sensation to the regiment batch area of the shoulder.
Apart from that,
There are 4 branches of axillary nerve. So tell what are the 4? One is what you said. Other
Yes,
3.
sir. So
The 2 different there, no?
what is Sohm-Sachs procedure?
So Sohm-Sachs procedure is when we transfer the triceps, medial head of the triceps, that is the radial nerve, to the axillary nerve.
Medial head,
Long head.
Long head, long head.
long head to the
Axillary nerve, sir.
entire axillary nerve.
To the anterior part of the anterior division of the anterior axillary nerve.
So anterior division supplies what fibers?
So the anterior division supplies the
Anterior
most
part of
fibers
what
of
are,
the deltoid, no, sir.
what are the parts?
Anterior, middle, and posterior part of the deltoid.
Posterior also. Then what is the posterior branch to?
That also supplies the.
That also supplies posterior.
Any other muscle supplied by posterior
Yes,
branch?
what lies beneath infraspinatus?
The teres
Teres
minor, sir.
minor.
Teres
Teres
Yeah.
minor is again an external rotator. Okay, that is also supplied by the posterior branch of axillary nerve. So, Sohm-Sachs did only for anterior branch. Whereas Berkeley he did for the whole axillary nerve because we felt teres minor is also important. Okay.
And the reason Bertolli did that was after 45 degrees of abduction, teres major becomes an abductor. So once you raise it, teres minor also causes abduction and external rotation. So that is advantage. So the plan is we also try to inner axillary now.
Rotator, these are all part of the rotator cuff. So as many muscles as possible, you try to innervate the rotator cuff, the shoulder becomes stable. Okay. In fact, Doy was insisting more than deltoid, we have to innervate what? Serratus. So can you describe how abduction happens? shoulder abduction, how does it happen? What are the muscles involved in shoulder abduction from 0 to 180 degree?
So what are the first muscles which are
What
initiation?
initiates? What initiates?
This supraspinatus and the deltoid.
Supraspinatus. Supraspinatus initiates. Suppose supraspinatus is paralyzed. What will they do?
Then
Or what will happen when your patient is lying down? What will happen? Can he abduct fully? Deltoid is working, supraspinatus is not working. Can he abduct fully in the lying posture?
If somebody asks question like that, you have to answer. No, what is obvious? Sir is asking.
yeah,
He can abduct fully.
he
That's why
can.
he's asking. Otherwise, so you have to be intelligent when you are answering an exam. You become so restless that you are waiting for it to get over, I think. So don't worry. Some more time is there. So coming to this plan, what you have planned or what you have put. So this has been highlighted by Susan McKinnon. So if somebody asks you what is this plan of using medial head to the entire axillary. So this is a Susan McKinnon's plan. She has modified Somsack, which was long head of triceps, to anterior division. So Susan McKinnon prefers to put it into the entire axillary now. And the medial head, because the medial head is longer and it can be easily mobilized for a longer distance. So these are the two things which will be asked about long head and medial head.
Out of these two nerves, suprascapular and axillary, which is more important for the patient?
Again, it's a good question. So we have already answered previously. So tell.
So
Suppose we have
supraspinatus is more important
why? Why not deltoid?
because initiation of abduction is from supraspinatus, sir.
That's all.
Something else?
What we aim to achieve by suprascapular neurotization? One is
All-
initial abduction and
Teres minor will also get innervated, sir. So
No, now you have got too much confused. So suprascapular now doesn't supply teres minor. Axillary supplies the teres minor. So suprascapular supplies supraspinatus and infraspinatus.
infraspinatus.
So we need extra. Yes.
External rotation. Okay.
because
So
axial rotation is very important for these patients. Okay, so it is not necessary that they should achieve full abduction. If they can achieve even for 30, 40, 50 degree of abduction with suprascapular neurotization, and
yes.
at the same time they achieve external rotation, they can do the normal activities. Okay, just by mere deltoid reinnervation, the limb is not of much of functional use if the suprascapular nerve is not working.
Correct. So basically the patient, what does he want? He wants to eat with the same hand. So if you want to eat with the same hand, you need external rotation. Otherwise, hand cannot bring to the mouth. So two things you have to remember what sir said. External rotation is important for suprascapular neurotization. And similarly in elbow, supination is also more important than brachialis because patients always complain they lack supination along with elbow flexion. Only brachialis improves, still patients are not very happy because they don't get supination. So these are the two things you need to remember both ways. For shoulder, external rotation is very important. For elbow, supination is very important.
Yes.
So what were you done? Anything else you got? Any more slides?
No, sir.
Thank you.
No,
No result, no interop.
you have not mentioned about the how you are going to rehabilitate his shoulder elbow.
elbow, that's what she said, Oberlin 2.
Oberlin.
Oberlin 2.
Okay. Why you want to give ulnar nerve fascicle to biceps? Why not vice versa? Median to biceps and ulnar to brachialis. Any particular reason, or both way it is correct?
Sir, when we do ulnar nerve to biceps, we use the superolateral, that is the FCU fascicle. So anatomically, it is nearer to the biceps branch. So we use the ulnar nerve.
That is the reason.
Nice new reason you got.
Ulnar nerve is not involved in this. Upper plexus lesion, ulnar nerve
Not in
totally
normal.
intact. Whereas
Yes.
median now, you have two routes, lateral root and median root. The lateral root comes from the upper plexus,
Yes, sir.
which is involved. So strictly speaking, 40 to 50% of the median nerve is not all right. So we don't want that to go to biceps.
Okay.
You are asked which muscle you will innervate among the biceps and brachialis, you must always say biceps. Because by getting a biceps, though brachialis is a very powerful elbow flexor, you get elbow flexion and supination if you do biceps. So the good nerve, you give it to biceps. The other one, if you want to do, you take the median nerve, select one nice fascicle and give it to brachialis. Okay. Not
One
because
more
it is-
reason, one more reason could be that why we select ulnar nerve fascicle for biceps is because ulnar nerve has got more number of motor fascicles.
Yeah.
It has got less sensory fibers as compared to the median nerve. Median nerve innervates, you can say 3.5. Ulnar nerve only 1.5 of the fingers, So ulnar nerve in the proximal arm is more having motor fascicles. So we have good chances of success in biceps innervation. Now you said that you are selecting how you decide that which fascicle is going to flexor carpi ulnaris. In your center, still you are doing that practice? That is the fascicular selection, or you just use randomly?
So superolateral fascicle is said to go, but in our center we are just using a motor fascicle of the ulnar nerve, sir.
Good. That's the right answer for Bandari sir, you have to tell. So that is correct only. What sir said is right.
Hari, Hari, what is you are doing actually? Because
No,
still I
so-
find, people
Yeah.
giving presentations from various
So,
forums,
yes.
and
So
they mention about still FCU.
yeah. So I will answer the question. We take the supromedial, or whichever actually the size matching fascicle. Just for the sake of showing the PGs, because we've got a lot of trainees around, we need to stimulate and show and confirm this is motor. Because everybody wants to know what is it stimulating. So just for the sake of completion, we stimulate. But we are not selecting the fascicle based on the stimulation. That is one. The second thing, the reason why, to add to both of your points, you can sacrifice a larger part of ulnar nerve as compared to median. So if the biceps branch is big, you can take a bigger branch of ulnar nerve without causing any distal deficit. And the third reason now why ulnar to biceps has been proposed by Susan McKinnon, which is again, she's of course, Bandari knows, madam is very particular about a lot of things. She says the median supplies the pronator teres and the pronator flexor mass. So if you transfer it for biceps, which is supinator, there can be some irregularity or confusion. So, but that is to be proven, but that is one of the justifications of using the median for brachialis, not for biceps. But yes, we don't decide the fascicle based on the stimulation. We take the fascicle, and just to confirm that it is contracting well, we use the stimulation. The other way around.
But we should not totally discard the nerve stimulator whenever we are doing the Oberlin procedures, means fascicular transfers. We must test the median and the ulnar nerve.
Yes.
Sometimes we'll find that your planning is totally what you have decided, it totally goes wrong. you find that median is showing better response than the ulnar nerve.
Yeah.
Okay, at that time you must use the median nerve fascicles for the biceps.
Yeah.
So
That is
that
probably
is the
extended pulses.
exactly.
Yeah.
Yeah.
Yes.
But what I do is, in ulnar now, I choose a dissect the fascicles, choose a fascicle which is matching, stimulate,
Yes.
and once you stimulate, you get a good motor response, whatever it is, FTP or HU. The remaining part, I again stimulate. And the
Yeah.
remaining part must have a stronger stimulation of the same group of muscles,
Yeah.
FCU or
Yeah.
FTP.
So
That is there,
I think
I boldly take it.
I think before we come to the end of this presentation, I would like to add that if you want to achieve 180 degree of abduction, you must have a functioning serratus anterior. In this case, the serratus anterior is not working. And how can we re-innervate the serratus? Is it possible or not?
What like
It
close to
is
it?
Where do you
Because
look
in
for
your
that now?
first slide, you have mentioned about one particular muscle, which has got M4 power. That can be used as a donor. That nerve can be used as a donor nerve for the long thoracic.
So the latissimus dorsi.
Very nice. Thoracodorsal. So what happens? Thoracodorsal, it divides at its terminal part into two branches. So one branch which is showing good response, it can be transferred to the long thoracic nerve. They are very close by, so direct cooptation is easily possible. So this is the other method of doing distal neurotization when all the roots are avulsed.
You can do intercostal also.
Yeah, intercostal, but yeah,
Take one or
intercostal.
two intercostals.
Yeah.
That is also very close by. You not dissect so much. You easily get two intercostals for serratus. In fact, Doy has published a paper in Journal of Hand Surgery where you have neurotized suprascapular, suprascapular and deltoid, and suprascapular and serratus. And he has found where he has innervated serratus, the movement is more, the shoulder abduction is more. Because if you study the abduction of shoulder, initiation is by supraspinatus. After that, up to 90 degree only deltoid. Only up to 90 degree. Beyond 90 degree, if you want, the scapula has to rotate. The whole scapula has to rotate. On the other side, you have trapezius. On this side, you must have serratus. So if you have trapezius and serratus, the whole scapula can be rotated. Only then you will have overhead abduction like that. And for that, you abduct yourself. If your hand is internally rotated, you cannot abduct fully. You external rotate, automatically, easily it will go. Okay, so all these matters in shoulder abduction.
So just to before we conclude your presentation, there is a video presentation in Apsicon this time, and Dr. Oberlin has come up with transfer where he not takes spinal accessory to suprascapular, and he takes a fascicle from the C7 because the C7 is intact in this case. So you take a fascicle from C7 and transfer it to the suprascapular nerve. We have also done, I think, Ashwath Acharya from Manipal.
Manipal, he has done
Yeah,
it.
we have published it.
Yes,
We have
published
done,
it all.
and I think it is being presented in Apsicon this time, the video presentation. So if somebody says don't sacrifice, like sir said, trapezius is a very important muscle. You should sacrifice. That is. I think, Madam Lakshmi, Madam.
Sir.
Yes. So we'll conclude. Is there anything you want to add or tell to the students? You are only examiner, so you have to ask what you will ask.
No, I think nowadays I go to Stanley and MMC as a whenever they have a medal exam or mock exam, the brachial plexus, they give it to me.
Yes, sir.
Only few centers they are who are doing it, even like Stanley, MMC, like that, Ganga Hospital. Those students are little aware of all these things. Other students, they are not. But now, if you see the incidence of brachial plexus, it is almost equal to cleft lip. Cleft lip
Yes. Increasing also.
increasing. And plastic surgeon has got a wonderful opportunity to take up this specialty. Of course, this is a difficult specialty. You have a long way to learn this, and the learning curve is also long. But if you dedicate yourself, definitely you can do good service to all these patients. Many times we see upper plexus totally ignored for 2 years, 3 years, and coming back. Okay, where you can give almost, if you see some of the Bandari's results, you can go back to almost normal activities. Same activity what he was employed before, the same thing you can do if we do them early. So
Hari,
yeah.
Yes, sir.
Hari, just before we round it off, I have listened Dr. Oberlin also. He says that we should not use spinal accessory now. He is
Yeah.
very much perturbed about the trapezius weakness, isn't it? Now, because we are doing regularly brachial plexus injuries, we are
Yep.
doing exploration. What we find, the branching pattern to the trapezius is not same in all cases.
Yes.
In some cases you'll find that there are more proximal branches. Once you explore supraclavicularly, there are 3, 4.
Yes. I think you lost your voice.
Bandari?
No, there is some problem. Even I lost my signal. I'm on the phone now.
Yeah. Hello.
Yeah.
Yeah. If we go more distally. Hello.
Yes,
Hello.
I'm hearing.
Yeah, if you go distally, for which I do the posterior approach,
Yes.
we are doing the distal now, distal spinal now transfer to the suprascapular now. We can preserve those proximal branches to the trapezius. So there is no question of denervating the trapezius and the trapezius action. Second, you mentioned that he prefers, rather than spinal accessory, he prefers the C7 fascicle.
Yeah.
As we have seen after doing so many cases of brachial plexus injuries, the quality of nerve is not same. Some nerves are very good donors, some are not that good. Spinal accessory nerve is a very good donor.
Yes.
Whether you use it for suprascapular or you use it for musculocutaneous, the results are very encouraging. C7 is, though it has got multiple, it has got thousands of fascicles, but they are all mixed ones. Spinal accessory now is more or less a pure motor now. So if you are neurotizing, if you are giving priority to the shoulder, I always give priority to the shoulder rather than to the elbow. We must have a very, very good donor now for the suprascapular now. We should
Yes, sir.
not, I will not go for even C7 is working and spinal accessory nerve is intact. I will never go for C7 to suprascapular neurotization. After doing so many cases, I have come to the conclusion that it hardly leads to any weakness in the trapezius.
Point taken, sir.
Yeah.
Yes, madam. Madam, you are wanting to add something? Lakshmi, madam?
Hari sir, actually these cases are done in only few centers. I want you people to summarize what they have to concentrate and how to choose, and little summary maybe.
I think as Purushothaman sir said, numbers of brachial plexus are increasing. And if you really see
Yes.
the Of course, there is complexity and learning curve, everything is there, which is there in any subspecialty of plastic surgery. So I feel that if more plastic surgeons take up this specialty, the future is very bright because you can always get a wide spectrum of cases. In our center now, actually, brachial plexus is one of the largest subspecialty growing area in the department, which was not there maybe years back. So if everybody starts doing it, then more people do, more awareness spreads, and it is a combination of plastic and orthopedics, because a lot of secondary procedures like wrist fusion and then shoulder fusion or any other osteotomies, derotation, all are done by the orthopedic colleague. So if you work with a close combination with an orthoplastic approach, I think the future is very bright. And now insurance covers most of them. Earlier we were getting poor patients. Now you saw this patient is an orthopedic surgeon. Actually, she didn't put the result. He's got an excellent result. He's got full abduction and good elbow flexion. So it is a very rewarding procedure, and the remunerations, if that is what people are looking for, is also very high nowadays. So in a 2.5 hour procedure with a 80% guaranteed outcome, you can really have a good career. Yes, sir. Purushothaman sir wanted.
I think all teaching hospitals should have this facility.
Yes.
So, I think, and probably the people like seniors can help them in establishing that subspecialty also. Can come there, demonstrate 1 or 2 surgeries, and get going. So it is not difficult, so people should start without delay. People whoever is not doing any teaching specialty hospitals, whoever is not doing, they should start and take this initiative.
Yes, Dr. Hari, are
Yes,
you
madam.
going to show any in exam for the examination of the brachial plexus for the sake of
Madam, she covered most of it. So that is I think we'll in sir's talk we'll have some.
Yeah,
So we'll
I
go,
have some of the
yes.
videos are there.
Yeah, sir's talk has the video. So we'll go directly to his presentation.
Okay, sir. Okay. I thank all three of you for the very nice discussion, and Nivedita, she presented well.